Regardless of which option you choose for your prostate cancer, it is imperative that we continue to follow you closely. And here's why. Because prostate cancer, if we get it early and we get it in the early stages and it's localized, the chances that we can cure that prostate cancer is excellent. However, there is always the risk that we may see that cancer recur. How do we do that? Well, the best way in which we can follow prostate cancer is the PSA. But that PSA is going to be a little bit different depending on which treatment we choose. So after surgery, that PSA should be really 0. It should be less than 0.1. Occasionally we get an ultra-sensitive PSA, which goes the second decimal point. And again, you can talk to your physician about that. But at the end of the day, if we start seeing detectable PSAs of 0.1 or greater after surgery, that means that we have to be concerned that there could be a recurrence of cancer. And again, that could happen in 6 months, it could happen in a year, it could happen in 3 or 4 years after surgery. But it's that PSA. After surgery, the PSA should be undetectable, and by that definition, ideally it should be less than 0.1. From a radiation-wise, routinely we should see that PSA below 1.0. Again, so a different classification on there. Because the radiation routinely doesn't just completely destroy all the prostate, it destroys a majority of it, but there are potential some cells on there which may produce a very small amount of the PSA. We know that if that PSA drops below 1.0, what we describe as a nadir, i.e. the lowest point, that there is an excellent chance that that patient actually can do very well from that radiation therapy. From cryoablation, it's very similar. We try to see that PSA below, hopefully 0.5, but 1.0 is also a cutoff on that. We're looking at any type of these ablation therapies, whether it's going to be cryoablation, whether it's going to be radiation therapy, we want to see that PSA hit low. We do not want to see that PSA rise up. And this pretty much goes across the board. Any type of treatment that you've had, PSA goes down. PSA starts rising up, we need to make sure that that isn't a potential focus of cancer. If the prostate's been removed, there really is no great reason why that PSA should start rising up unless there is a potential focus of cancer. If you haven't removed that prostate, but you have potentially some residual tissue around, and that could happen from cryoablation or radiation therapy or even high-intensity focused ultrasound. So if there is a potential tissue around there, that could be just non-cancerous tissue. But we should not see a persistent rise in that PSA, which is routinely we're looking at trends in that PSA. So if we consistently see that PSA go up every 6 months, and routinely it's 3 rises in that, we know that there's a high risk that there could be a recurrence of that cancer. And then where do you go next? You talk to your doctor about what is the next treatment. Do I still have cancer localized within the pelvis? Can I consider radiation? Do I consider cryoablation to actually freeze it if I've still got residual prostate tissue still sitting in there? Or do I consider something systemic? And by systemic wise, we're looking at hormone therapy. We're actually shutting down the testosterone production. And that leads to the final question. If we see a recurrence of that cancer, is that locally in the area where either the prostate remains or where the prostate used to be, or is it distant? Is it in the lymph nodes and beyond? And that's a very important question that needs to be discussed with your urologist.
Some prostate cancers are high risk, aggressive, and more likely to spread. Others are low risk, least likely to have bad outcomes. The biopsy says cancer, but current diagnostic tools provide limited information about how aggressive a man's individual disease is. So most men decide to treat prostate cancer immediately. Once treated, many men experience serious long-term side effects, like incontinence and sexual impotence. Immediate treatment isn't always needed, but right now a man can't be sure if his cancer is the kind that is likely to require treatment or if he's okay to wait for now. What if there was a test that could determine how aggressive prostate cancer is? Genomic Health is developing a new test to do just that. By reviewing the underlying biology of the tumor and using genes from multiple biologic pathways, the test can predict the aggressiveness of prostate cancer when diagnosed, allowing a man to make a more informed treatment decision with confidence, taking care of himself with more information and greater peace of mind.